Okay, hello everyone. So today, for this particular class, because it's actually really long, so we're actually going to cover antiplatelets, anticoagulants, and antifibrinolytics. So in case all the names sounds like alien to you, don't worry. So by the end of it, you'll know what is it about. So, but for this particular part one, we'll just mainly cover antiplatelets and some background first. So before we go through the drugs, so obviously we need to know a little bit about when do we need to use it and how does the normal physiological control of all the system. Right, so basically we're going to talk about the bleeding system in the body. Right, so when do we use all these drugs? One of the situations besides the myocardial infarct, the MI, or the ST elevated MI, STEMI, right, it's about stroke. So there's different types of stroke. So we've got the first one here is thrombotic stroke, we've got embolic stroke, we've got hemorrhagic stroke. So it's quite important to know when to use these drugs, because but the thing, it all manifests as similar symptoms like for stroke, because whatever the symptoms the person is showing for a stroke person, it depends on which part of the area of the brain is affected. So it doesn't really tell you, oh, because this person is having a thrombolytic stroke, therefore is having this particular set of symptoms. If the person is having hemorrhagic stroke, you have a different set of symptoms altogether. Actually, no, you can only determine it through MRI. Right, so but obviously it's from a different way. Like for example, if it's thrombolytic or embolic stroke, basically there's a blockage. So because there's a blockage of the blood supply, so therefore you don't have blood supply for a certain area of the brain. But for hemorrhagic stroke, there is a bleeding in the area of the brain, which then causes not enough. So basically the blood supply to a certain area of the brain has been blocked, because there's already an earlier area of bleeding which already basically just stopped the supply. So when you use antiplatelets or anticoagulants or antifibrinolytics, it refers to a reduction or not really reduction, an augmentation of the bleeding process. So basically, in a very layman terms, you say it's a blood thinning agent, or you can say something that yang mencai kandara, right, in Malay. So so if the person is already having a bleeding, like hemorrhagic stroke, obviously you don't want to give them another drug which cause the coagulation process to even happen, even delayed, because you want the blood to clot at the moment. But for embolytic or thrombolytic stroke, because there's a block, you want to clear the block faster. So therefore, it's quite important that normally the stroke person actually go through the scan and all, then to determine what to use, which area of the drug to use, whether you want to improve the bleeding or to reduce the bleeding. Right, so for overall, we're going to go through the coagulation process, the basics, and also the different drugs, right? So again, remember this whole topic is chopped up into 2 videos, right? Just because it's way too long. So how does thrombosis occur? How does a blood clot occur? So we already know that blood clot is a very important protective process, because there's a lot of minor injuries that happen within our own body or happen when we bump on something and so on. But we literally have no idea how it happens by all the micro cuts and micro bleeding. But our body is happy and safe and fast and efficient enough to really stop all the bleeding before we realize any damage. Right, so there's 3 factors that affects the formation of a clot. So first thing, there's an injury at the endothelium. Right, so secondly is there's abnormal blood flow. So this one refers to more disease state in a way, and hypercoagulability. So let's go through one by one. Endothelial injury refers to damage in the blood vessels, the inside part of the blood vessels. So it could be due to hypertension, hyperlipidemia, or this a little bit of inflammation and things like that, which damages it. So blood clot could happen, right? So that to prevent more injured, right? Right. Another one is about abnormal blood flow. So basically, what happens is that it's mainly referring to arrhythmia condition. So arrhythmia is the condition whereby the heart rate is irregular. So for example, if we use a rhythm like, I'm just using hypothetical just to cheer up the class. So like if you look at the tempo, like boom cha cha boom cha cha, so that if that's the normal rhythm, if it's a wrong rhythm, it could be boom cha or boom cha and things like that. So it's a wrong rhythm, right? So you can see that probably the heart is not contracting very well, so it might be longer time and so on. So this abnormal rhythm will actually cause turbulence flow. So the blood flow is not really that efficient, whereby it's not all the blood that enters the atria will actually goes to the ventricle and then goes out of the heart. So there could be some blood which are stuck at the atria, right? It doesn't really flow, or not all will flow through the ventricle. So basically there'll be some pools of stagnant of blood. So this stagnant of blood will actually introduce thrombosis, because the blood flow is not very good, so there can be going around at the same time, so it actually activates the clotting factors. Another part is the hypercoagulability. So these are basically those disease based, so that some of the individuals already have more higher tendency to form blood clots, literally. Maybe they have more blood clotting factors in their body and so on. Right, so I think I didn't really explain the endothelial injury very well. So basically, there's some injured portion, so it can be due to inflammation, as hyperlipidemia, so there's too much lipid and things. So there's those minor injury to the endothelial, which then start to form slowly deposition of arteriosclerotic plaque, literally. Right, so let's go through the part by part process. So the first one, so it starts off by an injury first. Right, so there can be some reflex vasoconstriction and things like that. And bear in mind, there's a lot of numbers and factors which are involved in the whole thrombosis process, the whole blood clotting process, because again, it's a very coordinated event, first thing, and secondly, you actually need things to happen really quickly. It's not something that, oh, there's an injured, so we need to quickly form our clotting factors now to stop the blood flow. Sorry, that's too late. So there's actually a lot of clotting factors, but they are resting, so meaning they're not really doing anything. So similar like the analogy for platelets, if they are resting, they are already being formed. They just need something to trigger it, so that they can be quickly turned into an activated form and start to do its work, literally. Right, so they can start to have some injury. So there will be some subendothelial matrix exposure. So meaning there's exposure of the second layer, which is not supposed to be, because the first layer is the blood is supposed to be in contact with endothelial surfaces only. But if there's exposure with the antigens, right, if there's a damage, so they're exposed to the second layer, so they're exposed to antigens which are not allowed there. So therefore, it triggers the process of platelets to come into place. Right, so that platelets, the first thing you need to do is obviously they activate, they will just have to stick to the place. So they have to have adhesion at the localized adhesion, because again, you don't want the blood clotting process to occur all over the place. It has to be a localized process, right? To stay on the place, stick there and start to form it. Right, so to start to form the thrombus, as you can see, the resting platelets are round, and when it's activated, it forms a little bit like a spread out egg. Right, so and then other factors will start to step in, like tissue factors, right, expression, and you have some fibrin forming in. So fibrin literally is like a cement, like it's like after you put the bricks in, you need the cement to strengthen the structure. So fibrin is the one that strengthens the whole structure of the blood clot, right? So this is what we call the stabilization. And the last part here is also fibrinolysis, the secretion of other TPA, plasminogen activator factors. Basically, the whole process in number 4 is to limit the thrombus size form, right? Because you don't want the blood clot to occur all over the place until it blocks the whole blood vessel flow. So it has to be formed, but at the right place, small enough size, or big enough size, if you put it that way, right? So therefore, so the drugs that you can use can actually target different parts of it, right? So there are some of it that I'll just start to introduce it over here. So if you have any doubt later on, you can just go back to the slides and check where they act on. Okay, so there's drugs that act on the first phase, which is the platelet adhesion and aggregation. So basically, there's this GPIIb-IIIa, which acts like a sticker to stick all the platelets together, right? And we have some tissue factors here, right, to put in to activate the thrombin and all. So and tissue factors, so which then increase or activates the formation of a more stable plaque. Okay, so this particular slide is to tell you what happens, the details of what happened during the platelet activation. So there's this requirement of this thromboxane, right? Thromboxane that activates its own receptor. So thromboxane is actually one of the downstream products of the arachidonucleic acid downstream pathway. So there's involvement of the COX enzyme, the cyclooxygenase. After activation of the receptors, so you can see there's a lot of downstream. It's one of the GPCRs as well, G protein coupled receptors. Overall, all the way, you got PKC activation, So here you can see eventually it can cause this activation of GP2B3A, right? So binding of this fibrinogen to this GP2B3A will then cause the platelet to form, to aggregate. So again, as mentioned just now, it's the sticker. So another part over here is also happening in the platelet. So there's a requirement of this ADP molecule, which is a downstream breakdown from ATP, the normal ATP that we know, the energy source. So this is the breakdown ATP to form ADP, which is floating around in the body, right? So it has its own receptors. There's two classes of it. So what happened over here is that there's activation of enzyme. Again, here, this is just to mention. So this one is actually activation of a GI receptors, right? So here I need to mention a little bit because it could be a little bit confusing. So GI, so upon activation, will actually cause inhibition in the formation of CAMP. So there will be inhibit of pKa. So this decreased pKa activity would then lead to activation. Okay, so you can see it's the other way around. So activation of receptors causes inhibition, right, which then inhibits, so leads to decreased platelet activation, right? So and another part which is over here. So this part I need to mention because it's one of the drug targets as well. So meaning if you want a reduced platelet activation, you actually need to reduce CAMP. Okay, right. Let's move on. So there's a lot of other factors as mentioned about the names and overall, when they start to name the system, it's actually all in Roman letters, right? So you can see there's a few factors which are the key ones, right? Not to say the others are not so important, but if you affect the key ones, so all the others will be affected as well. So one of the key ones is thrombin. So thrombin is also factor 2. So again, the 2 here is in Roman letters. So as mentioned just now, they're actually under inactivated form. In this case, it's prothrombin. It can be activated by factor 10A, factor 5A, and calcium. And also, in the end, it forms this activated thrombin. So the activated thrombin is important to then activate all the other factors as well over here, and also to activate the fibrinogen into fibrin, which then forms the cross-linked fibrin polymer to then stabilize the plaque, stabilize the thrombus, right? So what's the main function? So hopefully you know all this. So if you have something to inhibit it, so inhibit all this all together. So there's also another filler called anti-thrombin 3. So anti-thrombin 3 acts like a cofactor. But the effect is a little bit more specific, so need to mention a little bit over here. So which again will affect the drug function that we look at later on. So anti-thrombin 3 over here, it acts as a cofactor with heparin molecule, right? So together it forms this L, opposite L structure. Okay, so heparin is actually something that is formed in our own body as well, or it can be introduced as a drug, right? So what happens is that together with heparin and anti-thrombin 3, it can have it inactivates the coagulation factors. Okay, so it inactivate the other ones. So what happens is that it can form with thrombin. So it inactivates and then forms this way. So there's heparin. Heparin is the longer tail, but for thrombin to act, it has to work on the longer tail, right? So heparin and anti-thrombin 3, it can also form its own inactivation, but it doesn't require the binding over here, as you can see. So you can actually put a shorter form of it to bind to work with anti-thrombin 3, a shorter form of heparin, which can also bind with all the factors here. Okay, if your blur is okay, just to know that diagrammatically, hopefully it's easier for you to understand that the function of thrombin for some of the factors you require both binding sites, but some you just require one. There's no binding over here. Okay, move on. So this is when all the numbers come in, and bear in mind it's a bit of a headache for sometimes because it doesn't follow numerical order. Right, so the easy way to look at is I'll start from the center here. So the center one, which mediates the whole thing, is factor 10. Right. So we've got intrinsic and extrinsic pathway. So extrinsic pathway is the one with injury. So there's factor 7 coming into place to then activate factor 10. So there's the extrinsic, there's the intrinsic over here, which requires more factors, and you can see thrombin over here as well. So in the end, they all go through the common pathway. So eventually this factor 10 can interact with factor 5, factor 5, right? And then factor 2, right? And you form fibrin over here. So you may question that why the body needs so many different types of factors, because obviously if one factor is down, our body can still function, right? You need some redundancy in the system for that. So another part, the last part, is fibrinolysis. So remember, after the clot is formed, it's stabilized. Obviously the tissues and all, the injury will heal, right? So upon healing of the injury, so you can actually dissolve the clot, right? You don't need the clot there anymore because there's no more injury. It's being healed already. So you actually have this plasmin, which is the scissors, to dissolve the fibrin. So plasmin is available in the body. Right, so plasmin, again, like any other factors, is available in the activated form inactive form as well, which is a plasminogen, which can be activated by this tissue plasminogen activator. See, the names are not very creative. To then form plasmin. So the activity of this tissue plasminogen activator is controlled by the plasminogen activator inhibitor. Yes, so the names are not very creative. Details you can look through at the bottom as well. So basically that's the overall process of the whole thrombosis. So let's go through the treatment. So there's different classes of drugs, overall family, not even classes, overall family of drugs. Okay, you've got the antiplatelets, you've got anticoagulants and thrombolytic agents. So what's the difference between these three main groups? Difference is based on the strength of activity. So again, let's go through the process as mentioned again. So there's injury, the platelets have to stick there, activated, and you form the thrombin, proper thrombin, and there's fibrin. And in the end, you need to cut it off. So in terms of therapy, so if the person has no platelet not platelet formation, there's no thrombosis, right? So there's no extra blood clot that you want to dissolve. So the first thing that you can do is to reduce the risk, because remember, vascular injury can be brought by hypertension, diabetic, and so on and so forth. So if you reduce the risk, you reduce the formation of injury in the first place. So second part is platelet inhibitors. So when the first part is being formed already, you can put in platelet inhibitors to stop this process. If not, then if the process is a more severe form, there's more thrombus form, you can put in anticoagulant to stop the formation of this section. If there's already a confirmed block, you can use fibrinolytics. So maybe you may ask, why don't I just start with the strongest drug? But bear in mind, the strongest drug will also refer to the higher risk of side effects of bleeding. So literally, all the classes of drugs, all the examples of drug that we talk about in this particular class and the second part too, all has the side effect of bleeding. But again, the extensiveness will be different. So it depends on the strength of it. Obviously, the stronger therapeutic strength of it to reduce the blood to being clot, then obviously there's a stronger tendency to have a side effect of bleeding. Right, so so a little bit from the guidelines as mentioned, there's quite a few newer ones, Coagulation and things like that. So later we'll go through the different drugs as well. Right, so there's also other drugs which can be used for STEMI patients, but again, details will appear in other classes. Right, so pharmacotherapy, if they already there's a confirmed one episode of STEMI, so there should be on antiplatelets and antithrombotics for 1 year at least, right? So they can be on different ones, right? So it depends on which one they choose for. Okay, so a little bit about antiplatelets. So we go through one by one, starting from the mildest drug, right, to the strongest one. So we go through the mildest one for this whole class. So it's quite a big class anyway. So you can see antiplatelets is for prophylaxis, right? It can be used for prophylaxis because it's not a very strong stopping bleeding drug in a way. So, and it's for intermediate risk patients, right? Those not very high ones. So we've got COX inhibitors, we've got PD inhibitors, we've got P2Y12, remember the ADP one? Well, the receptor that it activates is P2Y12, and also the GP2B3A antagonist. Go back to here, right? So there's also the protective prostaglandin in the stomach. So if you block this part, so yes, there's more stomach upset episodes, right? So again, very important drug anyway. So who or which drug targets COX-1, which is aspirin. So remember, we want the drug effect to be pretty specific towards COX-1 because we want to reduce the formation of thromboxane. So aspirin is one of the good example. Another reason to use aspirin is because it's safe, and you can use it in a baby dose, so it has very minimal side effects. And aspirin actually inhibits the COX enzyme irreversibly. So it's good in a way because it irreversibly inhibits the COX enzyme in the platelets. So, but platelets do not have the ability to renew, right? So basically, it just inactivate the platelets per se, which is great. So you can use them in a small dose and have a long effect. So you just need once daily. Right, so but all the other NSAIDs are actually reversible inhibitors, so that's why it's not useful in terms of cardioprotective. Only aspirin is useful, right? So you can use it at a very high dose to get analgesic effect, but here we're looking at the baby dose, so it's 75 to 150 mg OD, right? So again, it's wonderful because it's a small dose, it's safe enough to use long term, but it has the safe cardioprotective effect that you want for low risk patients. Okay, so any other contraindications you can go and find out in the BNF, right? So looking at diagrammatically, so the NSAID aspirins will work over here, right? And there's also GP2B3A, remember the X-axis sticker. So this is when the other drug names you hear will appear, that you have abscisimmab, eptifibatide, and tirofiban. Right, so yes, they're all in different names, they don't sound the same. Okay, so this is inhibition of the final common pathway. Okay, and just now, as mentioned, it can be P2Y12 receptor antagonist, so it's Clopidogrel, ticlopidin, and prasugrel over here. So you have dipyridamole over here as well, which is actually acts an inhibitor for this degradation of CAMP, right? So if you inhibit the degradation, so there'll be accumulation of CAMP, right? So there'll be less activation, right? So yep, so you want accumulation of CAMP. So what's the MOA? You can refer to the diagram. So PDE3 inhibitor, so just now dipyridamole, so as mentioned just now, inhibition of CAMP degradation is a vasodilator. So it's not that commonly being used now. It was more old. So we're going back here. Right, so ticlopidin and another part is higher risk of neutropenia. So that's why it's more dangerous in a way. So we are moving away from ticlopidin. So mainly is clopidogrel, tirofiban, prasugrel. So clopidogrel is a good alternative. So here you look at the classes. So pyridine and tirofiban is a newer one. So you can see some of it are irreversible binding, some are reversible. These two are prodrugs. So when you look at it, this is just to show the brand name. It's called Plavix for clopidogrel. Right, so duration effects again is different based on the half-life of the drug. So here, just to mention a little bit about here, there's also withdrawal about major surgery, before major surgery. So what it means is that if the person is on clopidogrel, for example, and aspirin, but there's something else the person got while they are on the therapy, right? So that needs a surgery. So, but it's a scheduled surgery, so it's not really that urgent. So obviously you have to stop the drug before the surgery, because if you don't stop the drug, then during surgery, they can have major bleeding events because obviously you're cutting open the person deliberately, and the person cannot clot the blood very well. So you need to withdraw the drug before the major surgery. So these are the days which are recommended if you can actually wait for it, right? So if not, then obviously you have to tell before the surgery. Obviously, the patient has to disclose to the doctor that I'm on these few drugs. So they'll take suitable precautions, maybe to prepare platelets and things like that, to reduce the bleeding, right? So this is what all about. So that's why you need to know the pharmacokinetic parameters of the drug, right? Okay, so the last class of antiplatelets that we're looking at is GP2B3A antagonist. So basically, it's an antagonist for the glue, the sticky one that prevents the platelets from sticking together, right? So therefore, you prevent or inhibit platelet aggregation. So there's three examples of drugs here. But however, you can see it doesn't follow the class name of similarity. So you got abscisimmab, you got eptifibatide, and you got tirofiban. So these are very strong drugs actually. So they're actually used during an acute coronary syndrome, whereby there's an MI episode. So it's mainly in IV form. So you can mainly see that it's used in the A&E department. So because it's a very potent drug, so again you might expect there's quite high risk of bleeding as well. So and the difference between these three drugs, as you can see, is the size of the fragment. So the original one is abscisimmab, which is a much longer one. The effect is irreversible, but the other two is getting shorter, so the effect will be more reversible. So how to reverse it if it's irreversible in a way? So you actually need to give in more fresh platelets into the system so that it can increase the platelet aggregation again, because you're giving in too much in this case. And the other two, if it's reversible, is quite straightforward. You can just stop the drug infusion and wait for the drug to get out of the body slowly. Because bear in mind the half-life, as you can see, although it's a bit longer in a way, but it's actually still considered quite short compared to the other drugs, because it's about 2 hours each, right? So the remaining slides are just some text from the guidelines. So on when and how should antiplatelet drugs be used. So again, strongly recommended for you to go through the guidelines. Okay, thank you so much. See you in the next round for